ખાન સાહેબ છે પેલા છે તમે કીધા છે ને એ ખાન સાહેબ છે IMA ત્યાંના પ્રેસિડેન્ટ છે ચાલશે કોઈનું નામ નથી લેવાનું खान सर का बाहर दरवाजा पे लगा दे ये वाला अपना इस तरफ लगा दे इनका किस चीज का है IMA का है IMA का ही होगा तो रोड दरवाजे के बाहर लगा दे किस चीज का है IMA का ही होगा
He's an expert. Rather, we usually in plastic surgery or in any specialty, you go to one particular subspecialty, like microvascular surgery or aesthetic surgery. But this wonderful man is something I admire so much, and he has excelled in all the subspecialties of plastic surgery. I introduce Dr. Ashutosh, and I request Dr. Chintan to brief about his credentials.
Thank you, sir. Very good evening to everyone. Myself, Dr. Chintan Golani, plastic surgeon. I welcome respected President of Bharuch, IMA, Dr. Khan sir, respected dignitaries, senior consultants, colleagues, and ladies and gentlemen. Uh, it's a great honor and privilege to introduce today's esteemed speaker, Dr. Ashutosh Shah. ગુજરાતીમાં કે ગુરુ એટલે કે માત્ર જ્ઞાન નથી આપતા જે જીવન જીવવાનો સાચો રસ્તો બતાવે છે. Dr. Ashutosh Shah is one of them. He has inspired, mentored lots of residents, lots of doctors, young trainees. Every day are getting trained under him. And countless doctors, through his knowledge, have specialized in their field of education and their private practices. Sir is a pioneer in the field of diabetic foot care and limb salvage. He is the founder of Elegance Diabetic Foot and Ulcer Clinic and practicing in Surat since last 22 years. His Elegance Diabetic Foot and Ulcer Clinic is India's first dedicated chain of clinics for diabetic foot care. Through his tireless efforts, he has helped thousands of patients save their limbs and improve their quality of life. Today's topic, preventing amputation, advances in diabetic foot care and limb salvage, is extremely important because every doctor, irrespective of his specialty or practice, treats diabetic patients. આજે આપણે જે શીખીશું કદાચ મે બી કોઈ દર્દીનો પગ તો બચાવશું પણ તેનું જીવન બી બચાવી શકશું. Personally, I have had a privilege of learning from Dr. Shah. His humility, willingness to teach, and passion for patients' care make him an exceptional surgeon and even a better teacher. એક નાની વાત સાથે મારી વાત પૂરી કરીશ. પગ બચાવવું એ માત્ર કોઈનો લિંબ બચાવવું નથી, કોઈનું જીવન બચાવવું, કોઈ પરિવારનું આશા જગાવી અથવા તો વ્યક્તિનું માન સન્માન અને સ્વાભિમાન પાછું લાવવાનું હોય છે. With great respect and admiration, I request Dr. Ashutosh Shah to enlighten us to this topic. ચલો જોરથી તારી સાથે સ્વાગત કરીશું સર.
I request Dr. Sharat Kothari to give him a oral welcome.
આવી જાઓ ઓન ખાન સાહેબ શરદ અને હું બધા બરોડાની પ્રેડસ છે એક જ ડિપાર્ટમેન્ટના સિનિયર મોસ્ટ સિનિયર અને એનો 1 year જુનિયર આવી આવી થેન્ક યુ. So humbled by this introduction, and for the first time I am coming to Bharuch for this kind of lecture. Here it's written that it's the first chain of clinic dedicated to foot care. So this I'm happy to announce that we have started franchise for diabetic foot. So we have created SOPs, planning and training for doctors who are willing to start their diabetic foot clinic at your place. Now we have our first franchise opening on 18th of July in Vijayanagaram, Andhra Pradesh, and shortly we'll be coming in Pune, Cuttack, and Vijayawada. So this is the way we have trained many people. So today I'll talk to you. It's not moving. આમાંથી નથી મૂવ થતી. So talking about the diabetic foot clinic, as you all know, diabetes can affect your heart, kidney, and eyes. We all know that. But the dreaded complication is diabetic foot, which makes patient dependent on the family one who was earning some time is now becoming a burden on the family. So once you save a diabetic foot, means saving a limb, you will be saving the family. So today there are lot many surgeons and there are so many practitioners also. So my topic will be starting with some basic and we'll go to the advanced reconstruction. PPT પેલા મેં ડેસ્કટોપ પર છે ના ના આવી રહ્યા અહીંયા નથી. Okay. So talking about a diabetic foot, patient presented with this. So you can see a small blister here, and this can turn to this just in a day, and on the second day it will be like this. This small looking thorn prick can go like this. So diabetic foot spreads very fast. Here what we know is tissue is the time and time is the tissue. Whatever time you pass, a single day and a week, slowly the chances to recovery to the normal foot will reduce. So talking about today's topic, preventing amputations from wounds to wellness is our tagline. So absolute line of defense against diabetic extremity and limb first approach is our approach. Now wound is not just the wound. As I say, it's a fear that I'll be dependent on someone. I'll be not walking tomorrow. It's a loss of independence and it's a systemic damage as well as uncertainty where my limb will be there or not. And you all know that when we are talking, it's a paper and proven in the journal that every 20 seconds, one person is losing limb. One person's amputation is done due to diabetes in the whole world. And in India, we have 1 lakh amputation due to diabetes every year. So when you have a diabetes foot, it's not only an ulcer or wound, it's a financial drain. Repeated dressing, repeated visit to doctors, the medicine expense, doctor expense, transport expense, leave for your relatives and all. And it's a family effect. So diabetic foot is not only the surgical wound, it's a family crisis. And that's why when it looks like a small punctate wound, it can increase and go up to the big amputation. So why this happens? All we are practicing here and there as a separate clinicians for the diabetic foot. So there's a fragmented care and there are lot many avoidable amputation. You must be knowing that when diabetic foot amputation is there, 85% of them is preventable. Why? All of them, 85% of the diabetic amputations are preceded with the small ulcer. And if we treat that ulcer, I tell them it's a time bomb. It's a time bomb on the foot. When it will blast and take your foot, you don't know. So that tiny looking ulcer will take away the limb. So that's why to treat that small ulcer at time is very much important. So talking about this is prevention is better than cure. So it's an important to take an extra care of your feet if you are living with the diabetes. And you know that there are lot many complications. So how a general practitioner or a normal practitioner can be warrior for diabetic foot care? So you are near and dear to the family and you are all approachable to the patient. So patient will listen to all practitioners who are their family physicians. And you know that 80 million Indians are affected with diabetes and now it's growing. So 160 million feet to be treated by us. And your role plays, you need to identify foot at risk. I'll take care of this. You can advise proper dressing and you can refer them at very right stage to the right specialist. You can monitor the sugar and basic foot examination. So your role is very important. Here, my advice is to start a small basic diabetic foot care clinic at your place. You can send any of your staff for a basic intelligence to us. We can train them for basic foot examination. You can also do foot screening at your place, RBS monitoring and dressings, but no major investments are required. And those who want to have tie up or want to take some kind of diabetic foot clinic, this is my mobile number. You can save this number so that you can contact me later, so we can plan a training for you or your staff. So now, talking about the recent advances in diabetic foot, and which I'll take care of this. So you all know that diabetes has neuropathy. મગજની ચેતાઓ ખરાબ થઈ જાય છે. And all the three types, motor neuropathy, sensory neuropathy and autonomic neuropathy. With that there must be vasculopathy, એટલે કે લોહીની નળીઓ પણ ઘણીવાર બંધ થઈ જતી હોય છે. And then trauma. So all the three will cause a diabetic foot care, that we'll see later. Various deformities are created due to this three the neuropathies, and that can cause ulcer. So what you can do at your clinic, you identify various red signs. If you see any of this, you can refer it to the specialist. Color changes, redness or blackness, swelling, numbness or maybe burning, that small and non-healing ulcers, infected toenails or fungus in the web space, bleeding corns and calluses, or this type of blisters. These are all red signs, and this type of cracks can lead to infection in diabetic foot. So all these are the red signs where you can refer it to specialist immediately. And how to deal with this? So we'll talk about the basic care. Normal sugar to be kept with the help of physician, endocrinologist. Preventive foot care, daily foot examination, daily washing of the foot with mild soap. Usually what happens is we avoid water in diabetic foot, but you need to clean the diabetic foot. Then apply moisturizer. Cutting of nail, it's very important that you cut it right. You don't go in the angles, otherwise the ingrown toenail will happen. The shoes you need to take care of. Instead of pointed shoes, wide toe shoe is required, and check inside the shoes before wearing it. No warm water. Always keep limbs elevated and quit smoking. When you buy shoes, I'll ask all of you, should we buy it in the morning or in the evening? Anyone? Evening. Yes. So usually we all get some edema when we walk around. So evening or maybe in the afternoon, if we buy, it's the right measurement for our shoes. So talking about the plan of management. So these all were general care, what you can make your patient understand. But now I'll talk about the advanced things. So neuropathy cannot be reversed. Till now there is nothing found out that neuropathy can be reversed, so that the numb limb will not be safe limb. So we need to avoid trauma. So trauma avoidance can be happening with the offloading. What is offloading? To avoid pressure on the foot. We all are walking, so we cannot avoid pressure, but offloading is possible. You need to reduce the pressure, so that is called offloading. And people ask us, plastic surgeon, what dressing can be put on the diabetic foot that it will heal? But it is not what you applied, what you take out of it. So you need to take the pressure out of the limb, then the ulcer will heal by itself, and I'll show that and prove that. So now, what are the important points while considering the offloading? The offloading is different for all. The one shoe will not fit all. Now this is the classification. What you need to understand is, this is the foot of diabetic patient but no problems, so it's a foot at risk. Here just you want is preventive footwear. What we do with this customized insole scanning machine, where just you need to do the customized insole and you are safe. This is class 2 where that ulcer has started but not complicated, not gone deep up to tendon or bone. Here, if you do biomechanic surgery, I'll talk about that, and that ulcer will go away for almost lifetime. This is crippled foot. Still, it can be survived with plastic surgical techniques. And the last is unit amputation. We'll talk on all of this. And there are basically lots many investigation. There are the videos is also running. If you want to see the instruments, they are there in the background. So you can take this. So this is the podia scan. When you walk, a computerized plate will find out where the excess pressure is there, and depending on that, we plan surgery, we plan your shoes, we plan your footwear. This is the smart scan technology, which is Gujarat's first machine, where with the base of AI and your foot screening, we create insole for your foot. And these are CT scan and medical pedicure we routinely offer for our patients. Now talking about the main thing is offloading. Offloading can be of two types. One is external offloading, you do it with the shoes and all, and one is internal offloading, what we surgeon is doing. So talking about external offloading, this type of contact cast you all must have seen. We make window for the ulcer and the ulcer heals. This type of removable cast also are available. They also will help patient, those who are not ready for casting. Shoes, sandals, all can heal ulcer. This is the customized insole. We take negative impression of your foot in the foam, and depending on that positive POP, we create your insole. But nowadays we do it with this machine. Very fast, in 15 minutes you'll get the things. So this type of customized insole are there, and you can see only with the customized insole this ulcer has healed like anything. These are peg assisted offload. Wherever your ulcer is, you remove that peg and there is a offloading. So you can see that ulcer has healed. So problem of cast and this type of external offloading is they are heavy. You cannot wear that cast or shoes everywhere. Even in Indian condition, toilets are not clean. We cannot wear in the field. So patient usually don't wear them properly. And also it changes the life so much. They think that this is a dependency and they'll not cooperate. So is there anything possible that we can change from inside, and it can change the things that will heal the things? These are the other options of offloading. But main problem with the external offloading is when you apply cast or anything, it will take around 2 to 3 months time for ulcer to heal. The other thing is repeated cost. The fourth thing is when the biomechanics inside is changed, therefore the ulcer is happen. So instead of treating ulcer's cause, what we are treating is an ulcer. So when patient puts foot without cast, the ulcer will reoccur. So that's why external offloading has a limitation. So now what is must, what is to be required, and maybe the new thing for all of you is internal offloading. Internal offloading is a surgical offloading. We change some bones, we can transfer the tendons, we can modify the stiff joints, we'll change the things from inside, so that with simple protective footwear you can move around, and that ulcer will heal within 10 to 20 days, and it will not recur in your prolonged time. So talking about internal offloading, it is done in grade 2 cases or maybe grade 1 cases. Here you can see that callus. Just you excise the callus and 30% of the weight from that ulcer is gone. So once the patient of diabetic foot comes to your clinic, callus excision can be done by any of you. So please don't allow patient to go without a callus excision. If you do callus excision, you are delaying the ulcer. So callus excision is the most important part of the diabetic foot care. The second thing is, usually the foot ulcers happen at these 5 to 6 sites only. It can be tip ulcer, it can be IP joint ulcer, it can be metatarsal head ulcer, midfoot ulcer, heel ulcer, or maybe the dorsal ulcer. 95% of the ulcers are happening at these places only. You identify your cases, you remember your cases. 95% will ulcer will fall in this category. Now, after thinking, researching, lot many plastic surgeons have found that why these ulcers are happening at this site only, and they have found out the pathomechanics. So normal tendons has become tight, maybe the joint have become changed, or some muscle paralysis due to neuropathy. So all biomechanics have been found out till now for all these ulcers. And if you modify that biomechanics, the pressure will go away and ulcer will heal by itself. I'll show for one by one for all ulcers. So how we find out ulcer is with the help of pedobarogram or maybe the foot scale. So talking about grade 2 ulcers. Grade 2 ulcers can be at the tip or maybe at the IP joint. Okay. So why the tip ulcer is happening? Tip ulcer is happening due to this tight FHL tendon. When you walk, the grade 2 becomes like this. And if you release this FHL tendon, the ulcer will heal and you will not find out any ulcer. Ulcer will heal without doing any plastic surgery. If IP joint ulcer is there, it happens due to the tight intrinsic muscles. So when you are walking or when you are weight bearing, it is difficult to elevate your great toe. So what we do, we need to mobilize that great toe. So stiff joints are mobilized, and we do Keller's arthroplasty or maybe just release of the plantar fascia. All these procedure which I am describing will be done as daycare. Maybe most of them are under local anesthesia or just the popliteal block. So you release the plantar fascia and the ulcer will heal, or maybe if you are releasing the bone here, you remove the proximal phalanx and all the intrinsic which are tight will go away, and the thumb great toe will be mobilized, and you can see this ulcer will heal. So this is 2 years ulcer healed in 2 weeks only, and it will remain healed. Main problem is ulcer can heal with footwear also, but when you walk it will happen again. With these surgeries, ulcer will heal without major intervention and it will remain healed. That's the main advantage. So talking about deep ulcer of the toe, these are the claw toe, mallet toe, these are the causative factor of these ulcers. And when you remove this ulcer, what happens is this distal phalanx will touch the ground and osteomyelitis will start, and your toe will cause for an amputation. So what you need to do is you just release this contracted tendon, your toe will become straight and the ulcer will heal and it will not recur. So you can see that within 14 days time, this second toe ulcer has healed by itself and it will never recur. You can do major procedures like surgical tendon transfer also, but usually it is not required. So talking about ulcers on the forefoot means the anterior foot. Usually it happens due to these fat pads are moving proximally. So the cushion below the metatarsal head is gone. So talking about the MTP ulcer, forefoot ulcer is on the first toe, means great toe के base पे या फिर lesser toe. So these are two type of toe, head of the metatarsal ulcer. So first toe is very important. 40% of the weight when we walk is taken by the first ray, means the great toe. So that's why we need to make every effort to save this first toe. So when the first toe is clawing and this metatarsal head is coming down and it is causing ulcer, what you need to do is static fixation with the tendon. So what we do, the tendon which is taking this great toe up, we take it out and pass it through the metatarsal head, and so that static fixation of the claw toe and claw toe is corrected. So once that claw toe is corrected, your ulcer will heal and it will not recur. So for this, after this, you don't require any kind of specialized footwear. You just wear a protective footwear and this all ulcers will be healed. So till now with dressing, we understand that 2 साल से ड्रेसिंग चल रहा है, 4 साल से ड्रेसिंग चल रहा है, फिर एक दिन इन्फेक्शन हुआ, पैर कट गया. But this ulcer can heal within 2 weeks time, but we don't know it. So as a doctor, we should also get updated, and that's why we have kept this session today. Now, most of the time, the diabetic foot patients have contracted tendons also. So this is called pronation of the foot. Patient चलता है तो ऐसे चलता है. So great toe, medial part of the foot is contracting more on that side. And why it is happening? It's happening due to the peroneal tendon. So peroneus longus tendon comes from the lateral side and attaches to the base of the first metatarsal. And if you release this tendon, this abnormal pronation will go away, and then your ulcer will heal. So this is called modified Jones procedure. This kind of ulcer will heal within 10 to 14 days. Even forefoot ulcer is caused is tight tendo-Achilles. Your gastrosoleus muscles are so tight that heel is not taking any weight. Most of the weight is just on the forefoot. So if it is like this, you need to release your tendon. So this is a gastrosoleus tendon. It is tight, so not allowing foot to go up. So most of the ulcers will be happening on the forefoot. So minor correction in the gastrosoleus will help the ulcer to heal. So that various level you find out whether the gastroc is tight or whether soleus is tight, whether both are tight. Depending on that, you release TA and say that ulcer has healed. This is non-correctable deformity of the first ray. Means claw toe is so changed that you cannot even change it with the tendon transfer. There you need a bony correction. As this ulcer was for 2 years and patient was lucky not to get yet the osteomyelitis. Still the osteomyelitis was not there. So every possible thing to save that first ray has to be done. And for that, we have done the osteotomy and plate fixation and a plastic surgical flap. And you can see that 2 years ulcer has healed nicely. So basically, whether it's a soft tissue or bony correction, if you do that biomechanics corrected, ulcer will heal and remain healed for a long. If the osteomyelitis is there, you need to amputate that part or maybe corrected that part. Now talking about minor toe ulcer, we have talked about the first toe base ulcer. Now talking about the minor toe. So if the minor toes are there, it is happening due to fixed, tight metatarsal heads. So when you walk, this head goes down like this, and the skin is crushed between the ground and your metatarsal head. So what here you can do is 2 things. This the small head of the metatarsal are not that much important for weight bearing. So what you can do is, if it's there, you can do just a sliding osteotomy. So in this, when you do this type of osteotomy, when pressure is there, this will go up. So pressure is relieved and the ulcer will heal by itself. So you can see this, that ulcer has healed nicely. But if patient comes late and there is an osteomyelitis of the head, you need to excise that head. And once you excise the infection, the ulcer will heal. So most of the time you all must have seen various presentations from the various organizations where they see that after 6 weeks of this, ulcer is reduced like this. Ulcer is not to reduce, we need to heal that ulcer, and healing of the ulcer is possible, and I am proving it again and again. So you can see that this third metatarsal ulcer is there. But if you do X-ray, this is called weight bearing X-ray. Normal X-ray what we are doing, AP lateral, patient ऐसे सोया है, X-ray lateral में पड़ेगा, you'll see nothing. But if it is weight bearing, you can see this tendo Achilles is contracted, his foot is like this. So every weight is coming here only. So any diabetic foot ulcer, you take any X-ray, it should be weight bearing X-ray. So here with this osteotomy, you need to release the tendo Achilles. So when you examine a patient, when we examine a patient, we try to find out what is the cause of the ulcer. That is the different part in EDFC, Elegance Diabetic Foot and Ulcer Clinic. When we see the ulcer, we don't see ulcer. We try to find out what has caused the ulcer. And if we treat that cause, ulcer will be healed by itself. So sometimes there is, as I said, there is a pronated foot. Sometimes it's a supinated foot. Patient walks like this. So lateral side of the foot is damaged more, and you will get ulcer on the outer aspect of the foot. And that is happening due to tight and tibialis anterior. See, tibialis anterior is pulling the foot like this. So what you do, balance it. Tibialis anterior is divided, foot is balanced, or maybe you directly transfer it to the lateral side. So now pronation, supination is gone, ulcer is healed. Recently we have treated one case, 4-year-old ulcer, treated in Bombay for so many long. We have done this procedure, and in 2 weeks time that ulcer is healed. So you can see here, the both feet were in the supinated position, and after surgery it is straight. So this was the lateral side ulcer. It was not healing with any kind of footwear, and with this tibialis anterior transfer and VY advancement flap, that ulcer is healed. So always try to find out the cause, or if you are not in that training, you refer it to the specialist who can find out and treat that. So my aim is to prove that ulcers can be healed, it can be kept healed. So talking about midfoot ulcer has different pathology. It's not all about forefoot. Midfoot is due to collapse. Due to neuropathy, what happens is tendo Achilles is tight and your foot is numb. So when you walk like thak, thak. So always what happens is at midfoot level, there is a fracture. If the patient has fracture, patient will stop walking. But no, this patient doesn't have pain. They don't know that they have fracture. They keep on walking. What happens is the foot is collapsing. So midfoot collapse happens. Everything goes down, and this bone has caused the ulcer in the midfoot. So you need to identify this early. So you can see that usually if in X-ray you see ankle to navicular to cuneiform to second metatarsal is in one line. But if this line is broken, it's the start of a Charcot foot. It's a neuropathy of the foot. And you need to identify it. Usually it presents like a cellulitis only. The foot is swollen, foot is red. You expect that there is a cellulitis. But no fever, counts are normal. You get an MRI, X-ray. If it is weight bearing X-ray, you can find out this. And if you find out at this place, you can save the limb. If you are late, then limb has to be amputated. So if you find out at early stage, contact cast or orthopedician fixation will heal this ulcer. You can see that ulcer is healed. Now talking about hind foot, hind foot ulcer or the heel pad ulcer. Usually, previously it was told that heel ulcer is difficult to heal, but now it's not like that. We understand why heel ulcer is happening. Tendo Achilles is not working properly. Maybe it has ruptured, or due to tendinosis it's not contracting. So heel is wearing more weight. So in computerized pedovarogram you can see there's a red part. All weight is coming in the heel. So how that ulcer will heal? So here you need to repair that tendo Achilles, either repair or reconstruct with using this FHL tendon. And once you do it, that ulcer will heal. And you can even see it in the serial program that the red thing has now become yellow and purple. So you can prove it also to the patient. Now dorsal ulcer are not due to pressure. They are usually due to friction. So always see for the footwear. Footwear friction or maybe some dressing friction is the cause of the dorsal ulcer. Here normal plastic surgical treatment will help. So with the skin graft it has healed. So advantages of internal offloading is minor to small daycare procedure. They don't require even admission. Can be done under local or regional block. There is a low anesthesia risk of these high risk diabetic foot patients. Ulcer will heal without major plastic surgical flaps. अल्सर होता है क्या करेंगे, स्किन ग्राफ्ट करेंगे, बड़ा बड़ा 1000 रुपीज का ड्रेसिंग लगाते हैं हम लोग और फ्लैप करेंगे. Even we were doing the same before 10 years, but that flap again will make a hole. So now we have changed. So ulcer will remain healed for a very long time without recurrence. Like in cancer, we say cancer-free survival, 5 years, 10 years. So here in diabetics, there is a new concept, ulcer-free foot. So now we are measuring that, and we have been successful up to 99% with this biomechanics surgery. We are practicing for last 7 years these surgeries, and I think one ulcer has come again for the same region. We also are learning, and now it's a very good that ulcer is remaining without recurrence. Overall cost is less. See, any ulcer which is healing within 14 days time, no transport, no medicine, no tracing expense, and the time bomb is removed from your foot. So this is a very advanced surgery, but you need to find out what is the cause. There are lot many causes which are causing this. No need for expensive shoes later. Simple protective footwear can also heal this. Normal life and no time bomb on your ulcer. So then where the external offloading will stay? It will always there. Low risk diabetic foot patient like grade 1, you do footwear only. Patient is getting prepared for a surgery, health or wealth, both ways. They need to get prepared. At that time, you can give the external offloading. Patient is not willing or fit for the surgery, then you can give external offloading. But otherwise, all ulcer, you have seen the biomechanics, you have seen that is corrected and how you can change the lives of your patient. So talking about Elegance Diabetic Foot and Ulcer Clinic, we started before 7 years. Here what we do is first we do the podia scan diagnostic, then surgical debridement, then biomechanical reconstruction. Sometimes we need microvascular flaps. Then we don't leave patient at the closure. We provide them custom orthosis or footwear and a prolonged follow-up up to 3 years, 5 years. All of our patients are in our contact. We call them regularly, free of cost, and we have data maintained this whose ulcer is happening again. So that's why we can talk to you like this with this confidence. So normal therapy is what we do: sugar control, antibiotics, daily dressing, basic debridement, and sometimes emergency amputation. But now we need to identify. What I have talked is only about the pressure and the trauma, but diabetic ulcers have lot many things inside: occult ischemia, sometimes biofilm and the deeper infections. There are structural pressures also. Sometimes bony and tendons are exposed and they need plastic surgical reconstructions also. So talking about advanced reconstruction, which are plastic surgeons are blessed with, you can see this type of ulcers now. So this is the case of around 70-year-old male with atherosclerosis and necrosis and gangrene of this part, debrided by one of my friend, and you can see this. There's a exposure of the navicular bone. The first metatarsal is gone. Great toe is amputated. What you can do with this? Atherosclerosis vessel. We have done free microvascular flap. This is post-vac. The granulation is created, but still the bones are exposed. So we have taken a flap from the thigh. This is the thigh of the patient based on the artery and vein. And then the same artery and vein are joined at the anterior tibial artery and vein. So now that thigh skin is becoming live on the foot and covering the foot. So you can see this is the thigh area from where we have taken the graft, and this is the totally healed wound. And this is the patient who is walking on his foot. And what will be the time? What can be the time for this? 21 days. The other case, patient referred after some calcaneal osteomyelitis. You can see the whole tendo Achilles has gone. What we have done is, this tendo Achilles was not there. The skin is not there. Soft tissue is not there. What we have done is, we have this calcaneum is there. Below this, there is an FHL tendon, means flexor hallucis, which tendon which flexes our toe. We have taken out that tendon. I need to waste 2 minutes. Okay. So this tendon is removed here. Video is not moving. So the tendon is passed through this calcaneum, and through calcaneum again the tendo Achilles is reconstructed. Now tendon is exposed, bone is exposed. What to do? So then we have taken a muscle from the thigh, and that muscle of the thigh is anastomosed. The vessel of the muscle is anastomosed to the posterior tibial artery and vein. Here I am removing that flexor seat, and then we have given that muscle flap, and over that we have done the skin grafting. So you can see that after this, the wound is also covered and the tendo Achilles is done. So this is the muscle flap, over that the skin grafting is done. So tendon reconstruction is also done, coverage is also done with the plastic surgical technique. So otherwise this limb would have gone for the state amputation. This is again a male, huge ulcer. Similar kind of free flap was done. This is again from the thigh. You can see this thigh is primarily closed, and finally within 1 month time that has healed nicely. You can see the good reconstruction and contour of the foot. Now patient was very happy. 5-year post-op without special footwear he was walking on. So this is the good shape and the coverage, but there was a bulk. Now dil mange more. So we are plastic surgeons, we can do liposuction also. So we have done liposuction of that foot, and now you can see that same foot what we have reconstructed. So plastic surgery is endless. You can do any kind of reconstruction for this kind of flap, and microvascular reconstruction is the best to cover this diabetic foot. as they are very huge coverage is also possible, and they are very durable. You can walk on this without any care. So this patient is also walking. I think the video will not work here. Again, the large defect, a small defect has caused this. Difficult to close. Peroneus brevis flap was done, and after 30 days, this all exposed joint and bones were gone, and the patient is able to walk. The whole the calcaneum was exposed. Patient has vasculopathy, so vessels were not there. So we have done angiography and angioplasty for this patient with the help of vascular surgeon. And on the third day of the vascular surgeon, we have done the free flap. This is the muscle from the thigh which is anastomosed to the posterior tibial artery and vein. Over that we have put the skin graft, and you can see that patient's foot is normal and he is walking without any special footwear, and the time duration is just 1.5 months. A small ulcer, that small ulcer has gone in, tendon is exposed, someone has referred to us, peroneus brevis flap was done, and the ulcer is healed. This patient is walking again. Again, this what I am talking about was the midfoot ulcer. Just a 45-old lady. The bone was projecting from inside. We have excised that bone. It is called exostostomy. And then ulcer was healing. We have closed that wound, and now the patient is on air cast and still be waiting for this Charcot foot reconstruction. So how we are different than other? Traditional approach is dressing based only, single doctor, late intervention, sometime visit, no systemic monitoring, and 60% limb salvage rate. While in Elegance Diabetic Foot and Ulcer Clinic, we treat the root cause. We have a multidisciplinary team. We screen early. We always see opposite side also, and continuous monitoring of the patient, and our limb salvage rate or amputation prevention rate, બીજી જગ્યાએ amputation કીધેલું હોય અને બચી જાય, that rate is around 90%. We have this advanced therapies, gait analysis, total contact cast, post healing footwear. So this is Elegance Diabetic Foot. This is, I am a founder of this. We have a team. Rajiv Shah, you all know, is a great orthopedic surgeon from Baroda. Dr. Madhu Periasamy is my guru, and he is in Ganga Hospital, Coimbatore. He is our advisory panel. Chintan is my associate plastic surgeon. These are all associate surgeon. This is clinic manager, dermatologist, physiotherapist, dietitian, anesthetist, vascular surgeon on panel, and orthopedic surgeons on panel, endocrinologist on panel. So we have total team of specialists working for your patient. And main thing is, when you refer us, we return it back to you. We don't keep patient with us with germs. Once it is healed, it's your patient. We have home dressing care facility also, and this is whole our 55 people working for this. We do lots of awareness activities, camps. We have even done Dia Food Summit, which is Pan India Diabetic Food Conference done by single clinic. Lot many camps, educational activities. So we have learnt a lot. Now a question for audience: what is done for this patient? This is lateral ulcer. This is the ulcer on the 5th metatarsal head. What have been done? It's a supinated foot and head of the metatarsal ulcer. Tibialis anterior transplant. Very right. This was the patient of Bombay. He was treated for 4 years as SL Raheja and not treated ulcer. We have done the tibialis anterior transfer and osteotomy of the 5th metatarsal head. and it has ulcer healed nicely. This again bunion deformity. This great toe has done like this. So bunion deformity is corrected and the ulcer is healed. So we are saving lives, we are saving limbs and restoring the hope. Referring physician value, when you refer it to us, clear escalation of the your patient's care. From dressing, it will directly go to healing phase. Co-management communication, we will be directly in communication with you for the healing of the patient, or if you are physician and if you have referred us, then we'll be always in contact for sugar control. Then functional endpoint is not just the wound closure. We'll follow patient for a long, and you'll get the benefit of the patient trust that angri chindvanu punya. So we have EDFC community WhatsApp group. We have, tomorrow you will get a link where if you are interested to be learn more about diabetic food, you can be the part of that community. Will regularly post and discuss cases there. We have referral program also where you refer, we salvage them, then return it back to you for glycemic care and prevent the ulcer from happening again. So ulcer is not reducing by 50% in 4 weeks, or the ulcer size is not reducing, you need to refer it early. So thank you IMA Bharuch, hope you like this, and if you have any questions, I'll be ready for answer.
Is to identify neuropathy. Different ways to identify neuropathy.
Sir, so we have a machine there. It's called biothesiometer. In that we have two testing. One is vibration testing, one is touch testing. Touch testing is done with the 10-gram monofilament. When you touch that, usually we all feel that, but this patient will not feel that. We have 5 points where we measure that. So 3 out of 5, if not felt, it's positive test. In vibration meter is there. We slowly start with the elbow where there will be new neuropathy. Usually they have hands, gloves and stocking type of neuropathy, means sometimes hands are also affected. So we touch with the elbow, and then once the patient knows what you need to find out, that vibration, and we apply on the 5 points on the foot. Normally normal person will feel it 15. If it is getting delayed 20 second, 30 second, so it's the start of neuropathy. So you can early identify the neuropathy. Neuropathy cannot be reversed, but it can be stopped. So sugar control work of our friend Dr. Viral, this proper sugar control will prevent neuropathy from progression. Sometimes for neuropathy, if you come early to us for neuropathy, and if you have tinel sign positive, tinel sign means when you tickle on the nerve and you will feel the distal tingling. So if that is positive, we release the tarsal tunnel, like we do carpal tunnel release here for mediano. We do surgical tarsal tunnel release, means the posterior tibial nerve, the lateral peroneal nerve, we free it surgically. So more blood supply, more vascular, more oxygen, and your neuropathy will be reversed if you come early. So all diabetic patients should come early to test the diabetic foot neuropathy.
And role of vitamin B in prevention and treatment of neuropathy.
Sir, actually neuropathy will not be cured with B12, but there is something you need to give to the patient. So vitamin B12 is helpful for regeneration of nerve, what we believe. So that's why B12 is routinely given. With that, if you have a neuropathic pain, we give gabapentin. But it will not heal that neuropathy. It will just take over the symptom and give the blanket to that neuropathy, so that you will slowly get neuropathy. So instead, if you have neuropathy and if you are early, release it and you will get the recovery. So please.
Sir, first of all, I appreciate very informative lecture.
Thank you.
Questions to you earlier, specifically in presentation, so that is a different way. This is first time because your work and everything what you are doing, that is going throughout the lecture. My question is role of antibiotics in your practice. either IV or oral. How do you proceed?
So any patient comes to us, when we see any ulcer, we take a culture first. Then we start with the basic antibiotic, maybe augmentin or Ceftum, or sometimes nowadays Bactrim also for 3 to 5 days. Till that time, antibiotics culture will come. We have Dr. Pratik Savage and Dr. Chirag Chatwani at our panel. So we do online consultation. Our diabetics patient will not move here and there. We have all facilities for online consultation. We get them the online consultation with them, and we select the antibiotic as per the routine protocol, which are culture sensitive. But nowadays, lot many total resistant bacteria also are coming. But there are two new promising antibiotics are there. One is called Emroc, and other is Teddy-Span. Teddy-Zolid. So that you can use for this diabetic foot ulcer. But we are very reserved with this antibiotic, as we don't want resistant against them. So if it is a very superficial infection, we usually debride it. If it is deep infection, so no antibiotic will work on the dead tissue. So if any patient who is willing to take antibiotic, we don't give them antibiotic. Instead, we debride it, make the wound clean, so that infection is taken out. Then simple antibiotic will work. So in our clinic, we don't give major antibiotics.
And local antibiotics, local what solution or ointments you are preferring?
Usually we prefer only T-Bact, Mupirocin. Not much. Any other question, please? Hope this is at least I have given you some idea how the new diabetic foot treatment is moving, and we are one of the maybe around 18 to 12 centers in the India who are doing this work. We are training lot many surgeons for this. Today only our Vijayanagaram trainee was gone. Pune were coming in the next forthcoming maybe around 15 days. So we are spreading this work with EDFC franchise. Any of you want to be partner, just don't take franchise. If you want that, we can help you out with treating your patient. We have EDFC partnership program also, and we'll provide training also to you and your staff. And we have franchise also, those who are working in this leading a diabetic foot center and want to earn also from this, we have opened the franchise also. Any comments, anything you want to tell? No questions, but comments about the lecture.
Do you have any experience of using Cadomer powder or Cadomer solution?
Yes, so Cadomer powder we were using previously, but it helps when the biofilm is there. So usually we as a surgeon, and basically preferably plastic surgeon, we don't our basic, as I said, we don't try much with the solutions. We are usually prone for more debridement. So our guru, all of our guru, Dr. Raja Sabati from Ganga Hospital, he says no bacteria is resistant to knife. So we believe it. So if any wound is there, instead of trying for various powders and solutions, we debride that wound.
Time is tissue. The more time you spend with the ulcer,
The-
more damaging.
Day and week and months, whatever you are losing, the time is the tissue, as sir said rightly. Any comments, sir? You were enjoying it a lot. Thank you, sir. વિરલ સર, તમારા તો ઘણા પેશન્ટ સારા થઈ ગયા છે, કઈ કહેવો? So if you are all okay, and we are very thankful, the team Elegance. So this is Bhavesh. He takes care of all our diabetic foot patients. His medical officer, Dr. Chetan, is there. Chintan, you know. Avinash from the basic of our diabetic foot clinics. Raj is our home care dressing. Pratik is our OT in charge. He is our marketing in charge. And Khushi is our reception. So we have 55, but came this much only today. So thank you very much. And Sunny is our managing things for the OTs and all. So thank you very much. We hope that we can help you out with these patients. If you have any patients, We'll surely be happy to help you out with this. If you are willing for a training, then also we are happy to do this. And you have seen that advanced reconstruction, any of your patient who are willing to save the limb, we can do many advanced reconstruction. Due to time constraint, I have seen only that 4-5 cases, but we have done a lot of them. Thank you. So I'll invite you all to lunch. Sir, you want to say closing comments, anything? Photo.
I request Dr. Ravi present this moment to Dr. Ashutosh.
Thank you. Have a good day. Have a good day. Thank you. Thank you. Excellent. Thank you.
So everybody is very welcome for the dinner. Yes.
So dinner is downstairs and Jain is available if anybody is taking Jain food.
Thank you very much for your valued time, and it was indeed a very informative and very eye-opening lecture from Ashutosh. Thank you, Ashutosh, and we will continue association with you.
Thank you, sir.
Thank you.
Like,
cases both sides available. लेटरल वाला बधाने याद रहेगी એટલું મસ્ત મજા वो एक आंसर बोलतो
कौन? ये सर्जन है। Thank you all.
Sir,